Hi, John.
Hey, Jerry.
Thanks for coming in. So, John, tell us a little bit about rehab. How is penile or erectile dysfunction rehab versus sexual rehab different?
So the way I talk to patients about penile rehabilitation is that think of your penis like your biceps, Mr. Jones. And if you put your arm in a plaster cast for a year and you don't move it, when the cast comes off, your biceps has undergone atrophy. And the same thing happens in the penis when you're not getting regular erections. Except that atrophy, which is really collagenization, is permanent and irreversible. And so our efforts early on, post-prostatectomy, in our radiation patients, in our ADT patients, are focused on preservation of erectile tissue integrity, while in the prostatectomy patient, we're waiting for the nerves to recover. Erectile or penile rehabilitation versus sexual rehabilitation, which is a much more broad, encompassing term, really revolves around us being focused on things like sexual incontinence, on penile volume loss, on restoration of sex drive and intimacy in couples. And I think, as you're well aware now, there's a great interest in focusing on couples and not just the patient.
So speaking of the couple, when you see that couple, do you see them before the surgery or the radiation, or do you see them after? And what's your preference?
Yeah, my preference is always to see them beforehand. I have to tell you, in the patients who come to see me at Memorial Sloan Kettering in New York, the patients who come to see me before, which is about 15% of our prostatectomy populations, so it's not very many, even at MSKCC, right? So I love to see them before because these patients always have realistic expectations. And we can introduce the concept of rehabilitation to them early. All right, I know they're focused on their cancer and getting rid of the prostate or being radiated, etc., and the PSA kind of obsession, right? But they have realistic expectations. And I'm a big fan of prehabilitation. The concept really revolves around endothelial preconditioning, that if we can upregulate endothelial function before the injury, nerve damage at the time of prostatectomy causes endothelial dysfunction, then we got a foot in the door, a head start on protecting the erectile tissue.
So it sounds like a really comprehensive approach where you have the couple, you find out what their goals and objectives are, and then you discuss how you're going to manage it. How successful is it?
Yeah. So, of course, as you well know, there are no large randomized controlled trials showing that rehabilitation works. However, we have no data to show that rehabilitation doesn't work. And those two things are very different entities. And extrapolation science, if you believe in the ability for PD5 inhibitors, for example, to protect endothelium, the penis is an endothelium-laden organ. And so I believe, without us having level 1 evidence-based medicine, that there is no harm to doing rehabilitation. The big argument against it years ago, of course, was cost. And now with generic PD5 inhibitors, cost is minimal. And if patients don't respond to PD5 inhibitors early on, they go on to injection therapy. And we use generic drugs like Trimix and Bimix, and they're incredibly cheap. So cost is not a barrier. And what I want us to protect ourselves against is the concept of obsessive oncocentricity, that we're entirely focused on the PSA and we're not focusing on the quality of life. And what I want the clinician to do is give the patient the option of pursuing rehabilitation.
You know, I want to echo that, John, because in my own practice, the patients that are most unhappy are those that never knew this opportunity existed. And the fact that you're introducing it to them is incredibly important. So maybe we'll end by you giving us an idea, how happy are your patients? In other words, what's the satisfaction with the whole rehab program?
Well, before I do that, there is a randomized controlled trial published in the Journal of Clinical Oncology that shows if clinicians engage with patients about their prostate cancer-related quality of life, no matter what their sexual function outcomes are, the regret level is lower. That patients want to be engaged. Our patients who see me pre-therapy are so happy. They come in and say, I'm not sure what I'm going to get out of this, but now I'm so happy that I came and see that. And no one's ever said that this is a waste of time. Okay? I think that if we can get people back early after treatment, restore their intimacy, those patients, those couples are just more satisfied.
Well, thank you very much. This is incredible information.
My pleasure.